welcome to the Heart Failure Collaboratory Heart of the Matter podcast. And today we're here with my distinguished guest to talk about a very important concept in therapeutic development, design of clinical trials, and that is, how do we look at recurrent events as an important endpoint in clinical trials, in contrast to perhaps what we've traditionally used as time to first event? And this came up in a conversation we had in one of our Heart Failure Collaboratory think tanks, and I'm really pleased to have this distinguished panel here today, and we'll go around the room and ask them to introduce themselves and their title. I'll start with Brian Claggett.
Hi, Brian Claggett, statistician at Brigham and Women's Hospital and Harvard Medical School.
John McMurray.
Hello, John McMurray, Professor of Medical Cardiology at the University of Glasgow in Scotland, UK.
Natalia.
Hello, I'm Natalia Muhlemann. I'm a Vice President at Consulting at Cytower.
Great. LJ.
Thank you. This is LJ Wei. I'm a professor of biostatistics at Harvard. Thank you.
Stuart.
I'm Stuart Pocock, statistician at London University.
Thank you. John.
Gregson, statistician at London University and Boston Scientific.
And Marc Pfeffer.
Hello, I'm a cardiologist at the Brigham and Women's Hospital, professor at Harvard Medical School.
Thank you. Well, this traditionally, when we started this many, many years ago, heart failure clinical trials, we designed them with pretty straightforward mortality endpoints, and recognizing that mortality was coming down as in the event rates, we went to composite endpoints, and that traditional composite endpoint for many of our designs was time to first heart failure hospitalization plus cardiovascular death. But more recently, we've been, and the trialists on this call today have been advancing a concept of recurrent events, recurrent heart failure events, to perhaps better reflect the journey that the patient is on when they're in a clinical trial or when they're in their clinical course of their disease, but also an enhancement of the number of events when you do this. And yet, Brian, when you presented this at the collaboratory, the magnitude of advantage looked like it varied in different settings of trials and different examples that you gave. So let me open it up to you, Brian, to talk about, what is there any advantage of recurrent events, and, what is a recurrent event?
Sure, we can start with what is a recurrent event, which is why stop at the first event. If a patient gets hospitalized twice, we should count that. If they get hospitalized and then die, we should count that. I mean, I think our starting point is that it is probably a more meaningful endpoint, that these are patients who have multiple events, and so why shouldn't we be counting them? And so if there is a way to both use a more meaningful endpoint and to gain some statistical power, that's great. And so I think what we've seen so far, it's not a tremendous increase in power, but on average, many of our trials have shown more significant results when we use recurrent events rather than stopping at the first event. It's not a guarantee. It's not, it's something that happens every single time, and we're trying to do a better job of understanding when those scenarios might be. But for the most part, we tend to get a little bit better treatment effect estimate, a little bit better p-value when we count all the events.
And John, as a cardiologist and clinical trialist, you sort of dragged us into this in your design of trials. Or tell us your thinking about the movement across the different types of endpoints over the 4 decades that we've been in this.
Well, actually, I think I learned it from Stuart, but I think, Chris, the point is that as heart failure has become less of a short-term, extremely deadly condition to a more chronic condition with many repeat non-fatal events, we really are not estimating the true burden of the disease by looking at just time to first. And in fact, a few years ago, we looked at a lot of the trials we had, and typically in the trials that we do, maybe 40% of heart failure hospitalizations, 40 to 50%, and something similar in terms of deaths are second, or in the case of non-fatal events, subsequent episodes. So we're really missing a lot of the burden of the disease. And then there are other issues as well. I mean, in the real world, patients may stop taking their treatment. It is potentially possible that a disease becomes resistant to treatment, that treatments become less effective with time. So, of course, if patients are taking treatment for life and the effect of the treatment is less, then time to first may overestimate the treatment effect. So there are several reasons why we would want to look at total events first and repeat events. But I'm going to be controversial here, and I'm going to slightly disagree with Brian and say that actually I think that although the treatment effect sizes may have been similar when we look at time to first and when we look at total events, that the p-values might have been a bit larger, Brian, and the 95% confidence intervals a little bit wider in several of the trials. And I know that actually you've explained to us why we've seen that.
Yeah, and I think this could reflect, there's been some discussion about, is this a F versus ref phenomenon? I know, more of my direct experience has been on the PEF trials, where I think, at least in our accounting, we've had 2 out of 3 maybe successes where we had, more statistically significant results with the recurrent events. I think more of the perceived failures or draws where there was no clear benefit to the recurrent events feel like they're occurring more frequently in the ref trials. And I think that's maybe pointing to another direction that I wish we better understood. Why does this happen sometimes but not others? Yep, it's a good question.
Well, let's get our statisticians to weigh in here. I'll start with Stuart. And Stuart, you've been on this journey for a little while on endpoint selection for heart failure trials. What do you think of this movement?
Well, years ago, I was a great enthusiast for repeat event analyses in the CHARM reserve trial, for instance. All those decades ago, it seemed to really matter and help. But I've changed my mind, to be blunt. The trouble is, repeat events are, most patients have either 0 or 1 hospitalization in a typical chronic heart failure trial. Then there's a minority that has 2, small, and then smaller and smaller minorities who have 3, 4, 5, or 6, or whatever. So it's a highly skewed distribution. And that capturing that skewness and these multi-repeats in a small number of patients is very tricky in the analysis. So as John said, the confidence interval, when you estimate a hazard ratio using Anderson-Gill LWYY method, tends to increase in width. And therefore, unless the estimate of the hazard ratio is getting smaller, your p-value will get bigger. You'll have less stronger evidence. I think it's suited most in trials where you're expecting a delayed event, a delayed effect. So the Kaplan-Meier, if the Kaplan-Meier plots are verging outwards, and the repeat events equivalent plot will verge outwards more so as time goes by, then repeat events may be of value. My idea would be do both. Do time to first composite in a conventional old-fashioned way, and in addition, do the repeat event analysis. They will probably produce very similar results, and you ought to be doing trials that are so well-powered it doesn't matter which is the primary, because they will support one another. If you have one that is significant and the other is not, I suspect your trial wasn't well-powered enough, or the treatment effect is so small it's not viable in the future anyway. So those are my thoughts.
Great comments. We'll continue to go around the table. And Natalia.
Yeah, thank you. I'm actually a big advocate of simulating the trial over the range of the assumptions, and I think we need to take into account on what is the key assumption, what do we assume this particular therapy will do. If, as Stuart mentioned, we expect quite a quick separation of time to event curves, probably we won't gain much by doing recurrent event. But if we expect latest separation, and also it depends on what proportion of patients are more severe and will have recurrent events. If the recurrent events will be driven by very small proportion of patients, if we do sensitivity, as we have seen was done recently on the FDA submitted project, there is a risk that if it's driven by a very small number of patients and we do sensitivity and remove few most severe patients, we will lose the signal. So I think it's really important to look at what is the key assumption, what do we expect the treatment to do, and then do simulation and select the method which is most robust across the range of the assumption. And besides rate of the assumption, I think what's important to look at is what about missing data and different way of imputing data, and also how do we treat intercurrent event.
Thank you. LJ, you're never shy. What are your thoughts?
Thank you, Chris. Again, thank you very much for this opportunity to speak with distinguished guests you have here. Now, if I recall correctly, about 20 years ago, we actually worked closely with Novartis, also Brigham Women's Hospital. The reason was because we always use the first event that you said very well in the beginning. We wonder if we can repeat the recurrent events. I remember we went to FDA, we went to EMAR, we spent a lot of time to convince those guys to say recurrent events will give us more information. And finally, they agreed. Now, let me just make one comment. I think my colleagues here emphasize too much about statistical properties of using first event or the repeated measurements. Now, if you go back to clinical interpretation, forgive me, I'm not a clinical person, but I mingle with pregnant women people so much. I had a little bit understanding the clinical aspect. Now, think about it. If you use the time to the first event or death, after you finish, you got a successful result. In real life, how did you treat the patients? I said, okay, Chris, the patient take the medicine and then a few months later develop a hospitalization. And I said, well, should I continue to use this treatment after the first event? I say, sorry, sir, I don't have enough data. I don't have evidence to actually telling us, the next recurrent events that can prevent it from the treatment. So I think we should think about it from a clinical point of view, not to restrict yourself in regard about power or statistical inference. So let me stop here. Thank you.
Thank you, LJ. John?
Yeah, I think recurrent events are sort of seductive. You think that there's more events, so that's sort of what you should be focusing on, both from the patient's perspective and from the perspective of statistical power. But the trouble is, there's a lot of uncertainty to unpack in there. And first of all, you need to decide if your treatment will actually work as effectively after the first event, and part of that is whether your patients will actually continue to take the treatment or discontinue it. And then I also think that it's harder to model what's happening with the current events, and I'm not sure we're necessarily capturing all of the structure in the data and modeling them that well. For example, we know that there's an elevation in risk following a first event, but we often sort of ignore that when we set up our models. And we know that events cluster within patients, but sometimes establishing by how much and what kind of distribution that takes can be difficult. And so, I think with the scope for it to be very helpful to take these events into account, but it needs a lot of thought about how to do it best.
And Marc, you've had a recent example you shared with us of one of the post-MI trials that came out very different with the two approaches. You've been in this business perhaps the longest, as a clinical trialist, and you taught LJ his clinical acumen, which it was pretty impressive just now. Give us your thoughts. I mean, you've been through this whole history.
Well, I couldn't agree more with everyone, which is a problem. That is the problem. There's no right or wrong, but I think the name of the game should not be the p-value. The name of the game should be, how does this drug affect human beings? And Chris, I concluded my presentation by challenging you. It depends on the drug. If we have a drug that's already been approved and well studied, then we should use our judgment and take all the information and not just the one p-value for the one declared. If it's a new drug, then sure, you better really show me safety, efficacy. But I challenged you on an old drug like sacubitril/valsartan, well studied, bring it to a new population, and we just missed on the primary, but we didn't miss on the recurrent. Shouldn't we be more mature and use judgment about a drug like that? On the other hand, a brand new drug X, I have no idea what's going to happen, nor does anyone start it. We have hypotheses. It could actually be hurting people. We've been involved in those trials too. So to say recurrent, please stay on your medicine. If I'm a patient, I signed consent, and now I get hospitalized for heart failure, how do I know it's not the new drug X? So I'm not going to continue. So I think it depends on what we know about the drug, what we know about the population, and there's no one answer.
That's really well said. You know, I had a recent example, and this is where, Stuart, you said it so nicely. People use recurrent events because they get more endpoints, and it was a smaller trial. It was a really modest sample size, and they wanted to get a lot of events, and they didn't get the signal on the time to first. They got a signal on the secondary analysis of total recurrent events plus CVD. But when you broke down what was driving that signal, it was patients who were hospitalized for 5, 6, and 7 times. When you remove those people way out there, and I think they may be a different phenotype. They may be non-adherent. They may be non-adherent to the drug. They may be non-adherent to diet and things that can cause tipping of heart failure. When they removed those 5, 6, 7 repeat offenders, there was absolutely no signal. So it'd be fun, I think, Brian, for you to look at all these databases and say, what's driving the positivity of these recurrent event trials that you've been involved with? But let's go around finally around the table and say, if you were designing a trial today, that's the audience here. We've got the entire ecosystem listening. You're designing a heart failure, whether it's reduced ejection fraction or preserved ejection fraction with a new molecule that Marc highlighted. How would you choose the endpoint today? And it could be multiple choice. You could say time to first as your primary, recurrent events as your primary, or would you do something creative like Stuart's saying and split the alpha and have both of them as your primary? Or other, what's that good for?
I think I would have a lot of questions, right? I would want to ask you, what do we think? Is there a delayed effect? What do we think we know about the adherence discontinuation? I think you can go down that path and try to make an educated guess. I think probably the safer approach, it's going to be the what kind of evolved from our discussion, a month ago, which is why aren't we thinking about ways to do both and split the alpha with some minimum penalty, because these two results should be pretty correlated with one another. I don't think anybody has successfully implemented that, but I think we have more assurance that that is something that we can do, and that we just need to work out the details. So I think that is my go-to at the moment.
Very nice. John? McMurray?
Well, I mean, I think that recurrent or total events makes the most clinical sense, but the danger is that it is seen as a way of reducing sample size, and that's what you don't want to do. So I think your trial should be powered for time to first, but you should look at total events, because that allows you to do the things that LJ and Stuart have talked about, which is to look at whether or not the treatment really continues to be effective, whether it does reduce the total burden of the illness. But if you decide on a small trial because you think you'll get more events by looking at total events, then that's a mistake.
Yeah, well, nicely said. Stuart.
I by the way, I wouldn't split the alpha. That wasn't what I implied. I think it's good to have a sequential testing of repeat followed by kind of first, or the other way around. I'm very much sitting on the fence because I think it depends where that, as Marc put very nicely, it depends very much which trial you're doing. Where is it at? And if the two differ, then you're confused anyway. So I would definitely do both. The other thing is we haven't talked in this about the different methods for analyzing repeat events because it's difficult to do that in this short period of time. So once you've got to repeat events as somewhere, primary or key secondary, then you've got to choose your main method for that. And there are some interesting conversation to be had there another time, I imagine.
Another time. Thank you. Natalia.
I also would not split alpha because cardiovascular trial are already requiring high sample size, and if we split alpha, we need even more patients. So I would also do sequential or put one primary and one sensitivity. And I would look at assumptions and select by simulation between what will be my primary recurrent event or the time to event. And for recurrent event, I would actually prefer to use a method which take into account competing risks, so probably using frailty model to model it. But then yes, use one as a primary and then another one as a secondary.
Thank you. LJ.
Thank you, Chris. Well, when we publish a paper in New England Journal of Medicine Evidence regarding repeated recurrence events, the chief editor, before we published, he asked a very interesting question. He said, how can you put some kind of weighting for different hospitalization? Some people stay in hospital 2 weeks. Some people stay in only 1 day. Why do you want to treat them equally? I say, that's a good point. How do we put a weighting on those so-called? The longer hospitalization is worse than short hospitalization. Then I look at this literature. Amazingly, many, many years ago, my good friend, Marc Pfeffer, published a paper. He said, hey, listen, guys, why don't we figure out hospital-free survival days as the endpoint? If the guys stay in the hospital 2 weeks, I say, sorry, you lose 2 weeks. I think that's a terrific idea because quality of life also matters. It's not really counting how many events. And the different events have a different severity, and we should consider. So I think I'm quite convinced from now on, before we get into better idea, in couple of quality of life in our endpoint, the hospital day free survival is a good endpoint. Thank you.
Really nice points there. John Gregson?
Like others have said, I'll probably do both in terms of choosing which one as primary. I think my default would be the first event just for the simplicity and sort of ease of actually collecting the data and doing the analysis. Although it's heavily context dependent and depends on, for example, things that Brian was saying, pattern of treatment effect and pattern of expected discontinuation following first event.
And Marc, the last word.
Well, I have to say, I've been blessed to work with some of the best statisticians in the world, and that the days of life out of the hospital came from Stuart. And we did it in CHARM, and we knew the effect from time to first. And then days of life out of the hospital, turns out it's such a small number, but it was so important. It's just we weren't used to looking at that number. But back to your question, what would I do? I would study the patient population I'm bringing in. Heart failure is this huge tank. And if I'm bringing in sick people who get may get hospitalized or die. And if they get hospitalized, they're likely to die in follow-up, more likely. It depends on who are you studying. So if you're designing a new trial, question one, inclusion, exclusion, what do you think is going to happen to them?
That's really great advice and great concepts have come out of today's conversation. I want to explore more the waiting. I think a patient who gets hospitalized and goes to the ICU, gets intubated, and nearly dies is not the same as 25-hour hospitalization with one dose of 20 milligrams of IV Lasix. And we know that John McMurray has published that there's differences in the severity, but how do we weight those things? And Marc, I think we do have to take on your trial and sort of push it forward again and say, you're exactly right. That was a known molecule with a lot of good data behind it, and it just wasn't the primary endpoint. And so I want to thank my colleagues today for a really provocative discussion, and I thank the audience for being listening in and seeing if we can move the needle on our thinking about what endpoints we choose for the next clinical trial we do. So thank you, and look forward to your next trial.